Moderator for our next panel, Damle.
Hello everybody, my name is Damle. I'm the CEO of MEDgle, and our mission is fundamentally making sense of health data to help guide and scale care delivery. Our focus is helping moving data to insight to basically action through predictive and prescriptive analytics. I'm really excited here to be moderating this panel where we're focusing on the analytics of population level engagement. So everyone, I'd love for you to introduce yourselves and also talk about a little bit what do you think population level engagement really means?
Okay. I'm John Harris-Shapiro, President of Continuance Health Solutions. I guess we have many of us are data geeks up here. So Continuance is a data warehousing and analytics organization, and we broadly defined, we do population health analytics for employers, providers, and health plans. And in terms of what population level analytics means to me, it's the aggregation of individual engagement. So then the question becomes, what is engagement and what problem are you trying to solve? And if I had to think about it, I think of engagement as being behavior rather than attitude. It sounds like an attitude when somebody is engaged in a project, they're committed to it. But when we look at the analytics, I focus on the behavior side. How is that engagement manifest?
Hi, I'm David Perez. I'm the founder and CEO of Seamless Medical Systems. We have the Snap Practice patient engagement platform, and I think about half of the audience has touched it, filling out the survey for MedCity News. So you've had a little bit of experience with it. We're, as a company, really looking at data from the patient perspective, and our product is all really about the patient. And so, I just want to ask, has anyone ever been a patient in the audience? Maybe if all of us? Who has access to their healthcare information and health data? One, two, maybe. As consumers of financial services, we have access to every check we've written, every deposit we've made, every stock we own. We all have it here. We should have the same with our health information. Next to our financial information, our health information is the most important information we have. So I'm going to be talking for the next hour really from the point of view of the patient and how data can get to us as patients, how we can use that data to improve our health, and how that can be interfaced with our providers and really have a continuum, seamless continuum of data between the provider and the patient.
And just to interject, how do you think about population level engagement? Like, how would you define it?
Well, I think it's around using education and resources to motivate behavioral change, and that comes from many sources. I'll admit I'm not from the world of healthcare. Only for the last 18 months I've been in marketing and financial services. So I look at what's happened in financial services to motivate change. And if you think back in the 80s, the level of ownership of IRAs or 401ks or stocks was very low. And the financial services industry did a tremendous job of providing financial literacy to improve the literacy level of us as consumers, to then engage us in understanding what these products were and buying those products. So I think there's a lot of lessons to be learned from there. And then on the marketing side, predictive analytics and customer profiling did a lot to have us buy all the stuff we have. I think that can be, again, those concepts and ideas can be brought together to medicine to, again, improve wellness and health.
Silvia, please.
Hi, I'm Silvia Sacalis. I'm Vice President of Clinical Solutions at Walgreens. And my team really is focused on providing strategic clinical support to regional and national managed care payers. And I have a broad level of expertise that spans from IT into healthcare as well. And I'm really excited to be here today to really serve to provide the provider perspective. And as such, from a provider perspective, you had asked about population level engagement. The way that we look at population level engagement is a commitment to really meet the needs of all the consumers and the patients that we see on a daily basis, and really focusing down to the patient level, because serving the needs of a broader population starts with meeting the unique individual needs of every single patient and consumer that we interact with. Last, I guess I want to also focus on the fact that healthcare delivery is local. And so as such, Walgreens is uniquely positioned to meet the unique needs of patients in each local market through our extensive footprint in the community.
Wonderful. And you sort of brought this up, John. When you think about population level engagement, it's something we're all trying to do in the majority of health systems that are out there. And also as patients themselves, we are all trying to become engaged. But one question is, what problem are we trying to solve through engagement? It is an activity, it's something that we do, but to what ends are we doing that?
Ultimately, if we start going back to kind of root causes, if we were to take a survey in terms of what the number one driver of healthcare costs are, we would pick a lot of different things depending upon where you sit and whose axe you're grinding. But ultimately, it's people getting sick. And so, yes, we want people to consume services more effectively when they are ill or when they have an accident. But I think before that, if we want to get true to root causes, we want to help people become better stewards of their own health. And so that's the problem we're trying to solve.
Yeah, I agree with John, and I think that gets, being better stewards of your own health means reduced costs. So for the three big chronics like diabetes, asthma, and hypertension, you basically want people to help maintain their own health, keep them out of the hospital, keep them out of being seen over and over again, and then reducing readmission rates by educating patients after a procedure, say whether it's stents, to take their medications, adhere to the protocol, and keep them out from being readmitted to the hospital. So I think that's part of what engagement is as well.
And I think from my perspective, to sum it all up, I think you both touched on the key aspects of the triple aim, and just kind of level set, triple aim being improving patients' care and the whole experience in terms of quality and satisfaction, and then improving the population experience, and then reducing costs. So I think by empowering patients to be better consumers and utilizers of healthcare at an individual level, we can expand it to the broader population, and therefore really be successful in reducing the costs and really taking that triple aim to the next level.
And it's been said that you can't improve what you don't measure, but obviously what you measure sort of indicates your trajectory where you move forward. And as being the panel on analytics behind the population level engagement, I guess one key question is, what are the metrics or variables that you believe are key towards measuring and identifying sort of population level engagement? And I'm sure it differs. So whoever wants to start, Silvia?
Sure. So obviously from a provider perspective, a pharmacy provider, but also a broader healthcare provider, because we do service and provide services that are not just pharmacy services. We also provide specialty services, infusion, really managing patients holistically across the care continuum from the well to the sick. Some of the key things that we look at understanding from a variable perspective is, what are the barriers to patients being engaged? Because I think you need to start with the barrier, be able to identify what those are, to be able to help educate patients into how to overcome them. And so that's one aspect of what we look at. We also look at adherence. Adherence is a key measure of the success of that patient's treatment regimen. So if a patient is not being adherent for whatever reason, we really need to help them get engaged and get a better understanding holistically of the impact of that non-adherence to their level of care and potential progression of their disease. And then last but not least, looking further down the road, really incorporating pharmacy and medical, we really look at avoiding hospital readmissions, which are costly for the patients and costly for the payers, and also looking at avoidance of ER utilization when you could use a more optimal site of care.
I think one of the other areas that's exploding that we've seen are in all the personal measuring devices, so the spirometers, blood pressure cuffs, glucometers, and enabling and empowering patients with these technologies so they can be more aware of those particularly the chronic disease states. So they can be measuring their glucose levels on a regular basis, and instead of writing it in a journal and writing it down and maybe not having your glasses on and then bringing it to the doctor 3 months later, that data can get transferred immediately. So I think those are some of the measures that then a patient starts to learn where they should be, right? When are they in the green zone? When are they in yellow? When do they get to that red zone? And then even going further, what we're looking to develop is really a patient dashboard, so that the patient can have on their own device, their dashboard, and say, okay, my cholesterol level is such, and they can track it longitudinally. Or my peak flow readings have been changing this way, and you can see that. And by the way, the doctor can see it as well.
So just to iterate, there's a lot of data points, so quantified self-movement, et cetera, in terms of gathering data, enabling it. But how would you identify the ways to measure engagement? Like if I were to ask you, name 3 variables, what was your thought of the things that you would want to go ahead and see to give you an indicator of the level of engagement from an individual level and then potentially also from a populational level?
Well, individually, there was I don't remember the name of the company, one of them here that has a points program for taking your medication. Okay. That's a way to measure. Measuring the glucose levels, how many times a day, are they doing it? Is there a way to incent them outside of, yes, I want to be healthy, I want to see my grandkids graduate, What immediate need could be there? So I think those are a couple of things. John's going to speak.
From a population point of view, I segment the measures depending upon what segment of the population we're trying to measure. So if we're talking about keeping the healthy people healthy, I'm going to be looking for a relationship with a primary care visit. The medically homeless population typically represents about 1/3 of any given cohort, at least in the commercial employed segment. It's going to be different in Medicare, Medicaid, and so forth. So I want to shrink the medically homeless down, because at least people want to be at least engaged with a physician. I want to see if we have the data from wellness programs and population health programs. I want to see the person engaged in those types of programs. When we start looking at a population that has some sort of illness, then I want to see how many patients are getting their hemoglobin, or diabetics, how many diabetics are getting their hemoglobin A1C tested every 6 months, how many patients are following the various treatment protocols, and we could look for care gaps there. So I want to stratify the measures based upon the segment of the population that I'm looking at in order to do an assessment of a given engagement strategy.
Wonderful. But we've been talking a lot about variables and metrics obviously associated with population level engagement, but as a sort of a more fundamental question, why do you believe data is key to engagement? David?
Well, I think if you broadly say data as being information, so as I said earlier, with financial services, we have all that data. We know the bank balance. Imagine if in our bank account, we didn't know what our bank balance was, we didn't know who we wrote our checks to, but the bank said, we got you covered. We have your money, it's okay.
You need to know how much money you're making.
You didn't even know, maybe you knew that. But healthcare is like that. What does it cost? I don't know. Where's my information? I've got to go to sign a release form. I got to pay the office to give me the information. Then it's in paper and it's hardly usable. So I think we're at the point of technology empowering that ability to give the patient the data they need in a usable format for us as patients, not for the physician, right? The views are different, the language is different. So I go back to that dashboard, like if you have on my Wells Fargo account, I can see what I spent that month by category. And I know what came in, what went out. It's very helpful. So I could track, my daughter Martine, which vaccines has she had, which are coming up. Oh, there's the sports form that I have to submit for school. There's a physical for camp. Again, I don't have to dig it out, go back to the doctor, pay $25. All of it's there. So I think, again, from the patient point of view, I'm thinking what's useful to all of us.
I mean, in some ways, I've always thought of, data plus analytics enables a conversation. You get a response back from the data itself when you can analyze it, and therefore, through a conversation, enables sort of engagement. For you, how are you thinking about sort of data being key to engagement? Is this sort of a key for Walgreens? I'm sure it is. So.
Oh, absolutely. Data, I think, is the foundation for what we do at Walgreens. But really, to echo to John's point and to David's point, I think we are on the opposite side, right, on the provider side. So data for us drives appropriate interventions. To your point, if you could see when your child's had an immunization, you're very well informed. If we can see as a provider, if a high-risk patient has not had an immunization, we're in a position to intervene at that point in time with the appropriate intervention. So I think data should and can and has the power to really change patient engagement overall, patient health, improve quality of care. Having the data allows us to be able to understand each patient's unique need, because every patient that walks in has a different barrier, a different challenge, a different sociodemographic profile. So the ability for us to have that data in-house, to be able to readily access it and act upon it, so actionable data, I think it's what's going to drive really our success in being able to improve patients' quality of care.
John?
The way that I frame this discussion is that and I think it's extending what we're saying here, is that what we're trying to accomplish is a change. We want to change behavior. We've said that in a number of different ways. And there are three modalities for doing that. We can be prescriptive, which is literally perhaps writing a prescription. We can be educational, say, John, it really is important that you take this medication even though you don't feel like you need it. Or it can be motivational. And the data will help us customize and configure that type of intervention.
Wonderful. And, as we all know, and to your point, health data is not in any centralized, longitudinal, nicely organized format. As the previous speaker was talking about in terms of some, you may have 6 different providers, each of which is using a different EHR, each of which has therefore no ability to communicate with the other. And so you're basically getting these fragments of data across the board, or basically silos. How are you guys looking at how this is going to be able to be broken down, and we can really start getting a much more holistic or complete view of the patient, at the very least from a data perspective? David?
Well, we're taking it from, again, the patient point of view, and with SNAP, we're interfacing with a variety of EMRs and pulling data bidirectionally from them. So just in my own example, my primary care doc uses Athena. There's a portal for that. I did log in once. That was not a very great user experience. Greenway, it has another portal. I didn't even bother logging in for that because that's my ENT, uses Greenway. My children's pediatricians use eClinicalWorks, and they have a portal. As a patient, I'm not going to use all that. It's all fragmented. But with SNAP, what we're doing is bringing all that together. So there's one patient account, and that's all that back end is transparent to the patient, and they're able to pull that together. So I think there's a convenience factor.
Silvia, you were talking about some of the things that Walgreens was doing.
Yeah, so we've been very fortunate. We're really focused on the success, I guess, is based on data interoperability. And so we have our own EMR system for the clinics as well as for the pharmacies to really incorporate all the different types of services that we offer to patients today, ranging from physicals to healthcare testing to patient consultations, obviously the prescription information. So what we're really trying to achieve is a holistic patient view, so that no matter where that patient moves across the continuum of care within the points of care that we have out there in the community, we're able to really manage that patient holistically. But I think the broader point, and I think to your point, David, is it's going to require partnerships and collaborations with various providers and various payers out in the marketplace, because it's really a collaborative approach. I mean, different groups have different types of data, housed in different data warehouses with different portals. And so to really achieve the triple aim and do good for the bottom line and for the patient, we really need to work collaboratively to break down the silos.
Well, you saw that happen in financial services. You can transfer money between bank accounts. You can transfer stocks. You buy a stock, you transfer from Morgan Stanley to Goldman Sachs. So it's not like this road hasn't been paved before. Now we've got to bring medicine into the 21st century?
Yeah, we talked primarily about with employers and health plans. So these are organizations that are responsible for a population. So an employer has their employees, they literally bring their health status to work. So the employer has a vested interest in prompting engagement to improve and enhance their bottom line, customer service, and all those knock-on effects of an employer's health. What we find is that we are able to integrate data across the different employers' vendors. So it's not easy, but we do it very well. So we bring in health plan data, pharmacy data, electronic health record data, absenteeism, disability, work comp, and we bring that all into a platform so we can see the various connections and the various data points along the way.
Wonderful. There's quality metrics, especially, for everything from folks from HRQ to now the ACO 22 and 33. There's sort of engagement metrics that we've talked about, as well as potential social metrics. How are they different? How do you go ahead and compare them? Are they related? What are your thoughts on all these different measures? Because going back to the point of what you measure definitely sets the trajectory of how you potentially make changes and how you move forward. What is it you think of the relationships between these different metrics? Are they actually measuring, in effect, what we're trying to achieve is overall our goal towards wellness? And so what are your thoughts on that?
Well, measurement is an artifact of what data you're capturing. So I think we have to, when we start to talk about a program, we need to talk about what data we want to capture. And then we have to talk about when do we want to measure it. So if we do a program in 2012, when will the data be available to evaluate that program in 2013? Some measures move very quickly. We can see whether or not how many people walk through the door, sort of the basic measure of engagement. So that as soon as you collect that data, you can measure it and have a report in real time. Certain biometric values move pretty quickly. If you start taking your statins, your cholesterol will come down pretty quickly. Certain move a little bit more slowly, like body mass index, like many of us know about. Cost is the final frontier. That takes a long time to measure in the data. And if our ultimate goal is to make people more healthy and show that it has reduced costs, we have to be very patient. But you can have intermediate measures that let you know whether you're on track.
Very interesting. David?
Well, and I think just, as you were saying that, John, it occurs to me there was an earlier conversation here around, the movement to a value-based pricing. And data, that will really start to push that conversation in ACOs, because prior to that, if you're fee for services, sort of it doesn't matter a heck of a lot, because you're charging and you're doing services, but if you're getting to where what we really need to keep people healthy, then we need to study the data to understand whether it's socioeconomic strata, demographics, the type of condition they have, the geography they live. How can we start driving things more? So it's just more intelligent. It's adding a lot more intelligence to the system, I think, if you will.
Yeah, so from our perspective, as we know in the past, I think healthcare was really driven on the number of interventions, the number of visits, the number of tests. It really wasn't about the appropriate types of interventions. So I think quality interventions leads to quality metrics, also leads to quality improvement in care. So what we're seeing in the marketplace right now, working with all of our regional and national payers, is a direct focus on quality metrics, whether it's HEDIS measures, star ratings, ACO measures, you name it. And there's a lot of overlap between the different measures. They stem from each other, essentially. There's a lot of overlap. So I think there's now a need in healthcare and in the marketplace to really move away from the number of interventions to the type and the quality of interventions that are being delivered, so that we're more effective and making change and improving patients' quality of care. So from our perspective, we have a variety of different initiatives that we deploy through our points of care, whether it's our community locations or our clinics or anything we do in the specialty or in the infusion space in the home. We're really focused on understanding the payer's needs. So is it the triply rated measures for adherence? Is it something related to satisfaction? So we can help them achieve their goals. So very, very important.
And a lot of these things came about in effect through the Affordable Care Act. And so, the question is, what are your thoughts on how that has helped spur things? Has that helped move things forward? Has that helped us measuring the right things? Has that helped us focus actually on the population level engagement? Or is population engagement a derivative of that or a consequence? What are your thoughts?
I think we're going to find out. In almost every other aspect of our lives, what we pay has some relationship to the situation. If we're reckless drivers, we pay more, and we buy expensive cars, we pay more for health insurance. If we have a wooden house that's down by the Jersey Shore, we're going to pay more for flood insurance. We've insulated the world from what their health is. And the Affordable Care Act has extended things that have been in law for a while. HIPAA, I think, was the first one to put it in, where we could start creating differentials based upon not only wellness activities, but health status. So we're going to be starting to transfer some of that accountability to the employee. It has to be done responsibly, but I think we're going to see a sea change. I think we've opened up a new way of looking at the market.
Especially as you see the high deductibles now happening, as one potential.
That's the ultimate risk transfer, yeah.
Indeed.
I concur with John. I think he spoke very well about it.
And I think just in general, healthcare reform is going to be a huge impact in terms of the influx of patients we're going to see. So as providers, not just Walgreens, but any provider, whether it's a physician, a health system, et cetera, I think we have to use that data to be more efficient in how we care for these patients, because we're not going to be able to service all of them because there's going to be so many more of them. So utilizing data to really be strategic in how we focus and deliver appropriate care is going to be key to being successful.
Right, because we'll have this new influx of patients, but the healthcare provider population is not going to explode overnight, like the number of patients. Yeah. So efficiency is critical, and it's one of the things we're working on is also improving efficiency, improving the ability to have more patients flowing through the system by digitizing data and getting paper out of it.
As we talk about analytics behind population level engagement, I mean, we sort of touched on this sort of, I guess, 3 different pillars of motivation, engagement, and education. How are you guys feeling that these 3 sort of very core concepts are there, and as they relate specifically to the data measures you may have, and then subsequently to the analytics that you would find useful in actually helping push forward and really enabling engagement to happen at a patient level and then also really at a population level?
When we're looking at prescription, education, and motivation, we try to help our clients who are working with these individuals. We're providing tools to the coaches and the caregivers to provide them with metrics and scores that, if we see that everybody's doing everything right, but they're not adherent with their medications, that's an important part of our tool, then there could be an educational piece. If we see somebody who's totally disengaged, one of our success stories is for a client. We started seeing one-offs of young people with high blood pressure, high-risk cholesterol, glucose over 200, which is not good, and no visits to a physician. Nothing. And we took a step back from those one-offs and ran a population-based profile. And we found in a population of about 5,000 employees, about 600 or 700 of these young people that were ticking time bombs. So they used a different kind of approach for that segment than they did for the 50-something-year-old that isn't taking their medications on time.
Very interesting.
But I'd like to pick up on motivation, and some of the payers will, if you have got asthma or something, you'll start now getting on a program, and you get a letter that says you're now enrolled in a program, and if you've opened it and it hasn't gone straight into the trash, you may have read it, but then what do you do? So I think there's a lot to be learned from what's going on in social media. and the change of our culture around the use of social media. And no, I don't think people want to be posting on Facebook that they're diabetic or they have HIV, but I think there's places for social networks that will allow patients with particular health conditions to gather together and do it on a local level. So there's patientslikeme.com. Many of you are probably familiar with that. And if you're a diabetic, you can connect with someone in Paris. Well, that's nice to talk about diabetes and things, but healthcare delivery is done at a local level. And I think as a patient, I'd rather connect with somebody, I live in Santa Fe, and talk to, if my child had diabetes, who's the good doctor that treats diabetes in Santa Fe or in New Mexico? Which are the better health plans to support diabetes? Which hospital is the better health system? And that's only can be done at a local level. All that information is different in Washington. So being able to empower, again, the data and the information, then allow patients to engage with each other could be very helpful from a motivational standpoint. So let's say people who are trying to lose weight because they have diabetes, they can get together with a group of people, go out for a walk or go for a run, and cook diabetic-friendly meals. These types of things. So I don't think technology is the answer by any stretch of the imagination. I think it's an enabler in a variety of ways. Yeah.
And I guess I'll provide a quick perspective on that too. I think barriers, education, motivation, and engagement, all those four aspects are closely tied together. So our approach is we want to uncover barriers. We want to uncover what motivates patients. And then we want to take the time to educate them one step at a time. But I mean, when you're talking to a patient face-to-face in the pharmacy, for example, you have an opportunity for a teachable moment, but you don't want to overwhelm that patient and throw everything at them all at one time because it's going to go over their head and they're not going to have time when they've just recently been diagnosed with a chronic condition, potentially a very severe chronic condition. So we take a very consistent, systematic approach so that when patients come into our pharmacies, we peel the onion one layer back at a time, and we address one point of that care holistically each and every time, and re-emphasize certain very important messages. And then from a social perspective, we really focus and work really hard with very local community activist groups. So for example, for patients that have HIV, we partner with groups like ADAP and certain LBGH groups in the certain markets to be able to put those patients in touch with a community resource to kind of be able to share some of the challenges they're experiencing with people like themselves locally. They're nearby, they can access them. So we kind of want to close the loop in that patient care.
Since we're at least I'm from the Bay Area, there's always the ethos of social is the cure for all. I would love your opinions and your thoughts of social engagement, population level engagement, and also social analytics as it's coming now into a field of its own. How are you thinking that impacts population level engagement and some of the things you guys are doing? Silvia, do you want to start?
From a social perspective, we rolled out and quickly ramped our loyalty program, which we're actually really proud about, to help us better understand our customers and what we're seeing, what they're interested in, to really focus and learn more about how we can approach them. We've also rolled out a lot of different things with our website and the internet. We have the ability for patients to log in and see their whole prescription history. We have the ability to have them to chat with a pharmacist, potentially chat with a physician. So we are really deploying the social aspects of care in different ways. We also do text message outreach to patients for refill reminders. We also can call them if they're late on their prescription. So we're trying different methods to see what works best for each patient, understanding that each one is unique. One patient is just one patient.
Well, I think there's also a difference by disease states. Certain patients with different disease states are highly engaged. Some oncology patients are highly engaged with, on the internet. There's communities and chat boards, and as with anything on the internet, you don't know you have to really determine what's truthful and what's trusted or not. But those are patients engaging outside of their providers. And I think that's where we can take the road to them, if you will, where I think providers and health systems need to expand their reach beyond the walls of their clinics and be able to bring their trusted information, their expertise to those patients, and not just let them go and start talking amongst themselves without, some guidance. And what that's going to do too is improve patient loyalty. And really allow patients to really feel like they're being taken care of beyond just the time they went to the doctor's office and then left. And they forgot 80% of what the doctor said by the time they got in their car. I mean, we have one practice that has seen their loyalty rates jump by just implementing SNAP because their patients were giving referrals to other patients and saying, hey, this is a great practice. It's easy to use. There's no paper to fill out. And the practice is very hands-on, by the way. You go in, they're very friendly, they're very hands-on. So I think that social piece has to be defined. I think what sounds like what Walgreens is doing is really innovative, but it's not Facebook. It's not Twitter. Right. Cupid, that's really interesting. Yeah. Like, wow, okay.
That's cool.
Right.
Yeah, I'm going to take a step back, and think about social before we defined it as Facebook. There was a definition.
There was?
In the 20th century.
Fair enough.
And we are incredibly social creatures. We are programmed to respond to the people around us, and sometimes we call that peer pressure. And if we can leverage that in our culture, either in the workplace or in society as a whole, we can affect the change that we're after.
In our discussions, as preparing for the panel, we were talking about a variety of things, but one thing was interesting was sort of the commercials that were being run back in the 60s from a sort of cultural aspect, and basically talking about, how we need to take out the garbage and how we need to be much more responsible stewards of the earth. How are you feeling? Because, these days, how many times do we get an advertisement for Coke or any soft drink? How many times do we get an advertisement to go to the movies? But we don't get a lot of advertisements to go walk. We don't get a lot of advertisements to go run. So, how are you thinking about that with respect to population level engagement and some of the much broader strategies?
I firmly believe that folks that are vested in improving population health need to use the exact same tools that, and I'm not doing a product endorsement by any stretch of the imagination, but that McDonald's and Coke uses us to purchase their products. Constant messaging, peer pressure, as we just talked about, and so forth.
Right, and I think the question is, who's the advertiser? Right? Is it the payer? Right? The payers could be, right? It's their vested interest to keep people healthier. Go take a run, eat a low cholesterol diet, whatever it may be. There was, I think it was Will, who had one of the first keynotes yesterday, talked about the give a hoot, don't pollute commercials. So if you're growing up in the 60s and 70s, you remember those, the Indian paddling down the river and sees all the trash, he's got the tear. And that changed behavior for my generation of picking up trash, recycling, and being a steward of the earth. So as a marketing guy, I think it's a great challenge, and it comes down to who's going to pay for that. Right? Is it pharma? Well, if it's promoting their products, yeah, they may pay for it. The payers, certainly there's public service announcements. Those ads that I just cited were public service announcements. Right. Hard for those to kind of break through these days in the clutter that's out there. So I think it's a challenge.
So from our perspective, I think we do have a lot of partnerships with different groups like the ADA, and we do walks. And so when we see diabetic patients in our pharmacies, we emphasize the importance and we suggest that they come out. And so we try a multifaceted approach. I would say I don't think there's any one easy answer to combat all the messages they see out there. They see messages about drugs, good and bad and scary. And so I think we are in a unique position that when we do see patients, we can reinforce the positives versus the negatives, set some clarity around what they're seeing. I think it's just consistent communication with patients. Otherwise, we're really going to have a hard time combating things they've seen over the years for 20, 30, 40 years and changing that behavior right away. So I think it's one step at a time, reinforcing positive messages, doing it in a very positive, encouraging fashion, because no one wants the stick, everyone wants the carrot.
Well, and I think it needs to be personalized too.
Yeah.
So coming, and I go back to that the provider, whether it's the solo doc, the health system, needs to be engaged with their patients. And that's a little different than I think what we're talking about. And being able to use the data to target that information and understand those people. Will a stick work better? Will the carrot work better with you or me as an example? And when we have the intelligence to do that, data, we have the analytical skill to do that. So then that can be personalized, and then here's where tech comes in. It gets delivered when you're in the waiting room, but then you can pick it up on your phone, and then now it's more personalized than just give a hoot, don't pollute. It's like, David, don't go out and take your walk today, measure your peak flow, whatever it may be.
I mean, we're slowly running a little bit out of time, but very quickly, any quick successes you've seen in, population level engagement?
Yeah, we recently completed a study for a hospital relative to their employee health plan. In 2012, they re-engineered their wellness and health improvement program, very multifaceted program involving internal folks and external vendors. And we were able to program, our measurement period ended in December. In the first quarter, we were able to demonstrate a significant improvement in the organizational well score, which is a product of ours. If you think about like moving an organization's credit score is not easy. Yeah, not the corporate credit score, but the score of all the people in it. And when we took a deeper dive into it, we could see more people engaging with their primary care physician, more people on medication for chronic meds, more people turning out to the fitness center, and so forth.
And were you able to determine any specific root cause?
No, we believe that it was the net of everything. We could see improvements across the board. The personal intense programs like clinical health coaching had huge improvements in health. The cheaper programs like online health improvement programs had a modest impact. So we think it was the combined effect, yeah.
I have 3 successes real quick I want to highlight. Most recently, we just presented at ISPOR, hot off the press, some data around a cohort of patients that was followed, and they're MS patients, multiple sclerosis patients, which you may or may not know have very complex regimens, and they have the potential serious adverse effect profile. So a lot of MS patients are not compliant just because the drugs make them sicker than if they didn't take the drug. And we saw a 31% increase in adherence for those patients that we were able to manage on an actual program to help them stay compliant. A second one we've done now nationwide from a community pharmacy perspective, we rolled out an initiative called New to Therapy to really engage a patient when they're new to a treatment regimen or new to a disease state, to educate them right off the bat from the very, very beginning. We've seen a lot of success in various chronic conditions. And last but not least, one thing that most folks don't realize that we do, we also provide home infusion services. We also provide infusion services in what we call alternative treatment sites. So really putting an on-site location where a patient needs an infusion, it could be at the employer site. And that's something that really speaks to our desire to meet the patient's needs where they are in that continuum of care.
Wonderful.
Questions?
I guess we have room for 1 or 2 questions. Once you come up, please sort of identify who you are and your background so we can give proper context to answering it.
Hi, my name is Sandra Raup, and I'm in my heart a clinician. One of the things I've been noting is this sounds very prescriptive and educational and one-directional. Is there any way you can incorporate into population methods a way of getting information from the patient about what they want, what their goals are, what their attitudes and points of view are? Because I think a lot of times patients they're the ones doing this, so they're the ones that are carrying out their care plan. It seems like that would be critically important to not just tell them or talk them into doing something, but understand what their personal perspectives are.
I'd be happy to address that first. So I think you're dead on. So Walgreens does focus groups to better understand patients' needs and what patients are looking for in terms of how the care should be delivered for them and challenges that they're experiencing and what things we can improve in terms of the services that we deliver. And the other thing that we do that's actually deployed through our technological capabilities is when we do what we call a very focused face-to-face patient consultation, we have the ability through our technology to gather their input and enter it into the system, because ultimately closing that gap, the payer also wants to understand what are the patient's challenges. So we're very much, to your point, we want to kind of close the loop and definitely take the patient's feedback, and we do to date.
I'd like to expand on that. There's opportunities at the point of care, which is what you're talking about,
Right.
and what SNAP would do. There's also opportunities for even before somebody becomes a patient in the classic sense of the word. When you have population health programs being run out of the work site, there are tools, the common term for them is health risk assessment, which is kind of an ugly term, which is a self-reported survey tool where you can capture attitudes and priorities and needs and look at it from a population-based point of view to drive your programming. And then if the mechanism is in place, and I'm on a project right now that's doing this, to take those survey questions that you're asking as that the employee or the individual is filling out and channeling that to you as the clinician, so you can see their attitude, their engagement, their priorities, and that sort of thing.
Well, it takes me back to financial services again. Well, first of all, it's about personalization. And it takes me back to financial services. You sit down with an investment advisor, first thing they're going to ask you what your goals and objectives are,
Right.
and your level of risk tolerance. And it's different language, but it's pretty much around the same thing. You know, what are your goals and objectives for your health? You know, how do you take care of yourself currently? Family, social, medical history is a piece of that. So I think that's all got to get fed in. And again, this is where technology has to come in, fed into whether it's the EMR system or some intelligent system, intelligent decision support system that could help the clinician design a treatment program for you, for me, for you.
I think we have one more question.
Yeah, speaking to that point, you know, in looking at the data that goes in, like in the financial services model, they plug that into a SunGuard platform with Ibsen charts, and that produces a Monte Carlo analysis that gives an efficient frontier that says, based on your expenses and income today, 17 years from now, here's what you need to retire. So, but the analytics is not the data, and it's not the software, it's the algorithm and the Monte Carlo analysis that's used for that. One example, another that, it was a book that came out last year, The Power of Habit, and they spoke about tracking retail sales where they could predict when someone was pregnant. They predicted when a young teenage girl was pregnant by looking at her purchase history. And they went and started sending her coupons for diapers, and the father went to Target, said, why are you sending my daughter this? Come to find out, Target knew she was pregnant before the father did. So, you know, those kinds of analytics are out there. And actually, there was a conference at the Gaylord Center that ended yesterday. The HIMSS has a focus group on clinical and business intelligence applying these issues. And they're talking about a FICO score for healthcare. What are your thoughts around that? What do you see about these analytical metrics? What analytical tools might be out there? Do you see that kind of stuff being done, applied to population health management? Like you said, the predictive modeling and things like that around it. And if so, what are some of these metrics that we might see?
Yeah, well, we can talk afterwards. WellScore is intended to be like the FICO score. Yeah, that's our product. I don't want to make this into an advertisement. So.
We also do deploy predictive analytics today to better understand patient behavior and stratification of risk. So we do have a lot of data in-house capabilities. We also have an outcomes department that measures the success of some of the interventions that we've performed at different levels of risk. So it's there in different phases, I think. I think in the future it's going to definitely evolve to be much more robust. But I think right now, different entities have different aspects of predictive analytics as well as technology to be able to identify the successes of those populations you've intervened upon.
Funny enough, that's exactly what we do and focus on. So I guess we ended up perfectly at the right point for me. First of all, thank you so much, everyone, for taking the time. First of all, I want to give a great round of applause for the panel here. I'm sure many of them will be around to have future conversations to continue the, and continue the engagement. Once again, thank you so very much, and we'll have a great night. Cheers.